So today we have a presentation on the gastrointestinal tract and disorders in older adults. I'm Donald Jurivich. Many of you probably know who I am. I'm a professor of geriatrics at the University of North Dakota. And this program is part of the Dakota Geriatrics Workforce Enhancement Program that is funded and sponsored by HRSA. We can have the next slide, please. So the goals for today are firstly to understand the normal aging of the gut. We want to recognize and treat common symptoms and problems with the gut. And we want to take a peek, just a very brief look at nutritional concepts with aging. Next slide, please. So there's a whole list of things that have been observed with the normal aging process. And then some of these processes are compounded by either medications or other over-the-counter supplements, for example. And so at the top of the list here is the oropharynx. And we have some mild impairments of the neuromuscular coordination, so that can lead to disjointed swallowing, which can be exacerbated by small strokes or major strokes. The concept of xerostomia is dry mouth, and that can be basically from an underproduction of saliva that can be made worse by certain medications. There's bone loss that occurs, and so the alveolar ridge that goes around the teeth gets thinner and may cause problems with dentures, if there are dentures, or even retention of bone implants. In terms of the esophagus or the food pipe, there's lower esophageal sphincter pressure, and it doesn't relax quite as well. And there is also what's called secondary peristalsis, where the squeezing of the food pipe occurs without being well coordinated. And then the lower esophageal sphincter also has issues with pressure. And then moving into the stomach, there's slower transit time or squeeze of the stomach. There's some volume decreased and reduced mucosal barrier. And then heading down into the gut, there's some evidence of decreased drug absorption. There might be some changes in the gut immune system, leading to increase in either diarrhea or loose bowels. Next slide, please. In terms of the liver, we know that there's changes in the liver that cause altered medication metabolism. I always talk about the decreased alcohol processing, and I call it the 2-for-1 rule. So for each alcoholic drink, it's actually the equivalent to 2 drinks as we get older. It's important to realize that the metabolism of alcohol is not as good as when we were younger. And then in terms of the pancreas, there might be some subtle changes in secretion, and that's really not such a big deal with normal aging, but may become a bigger deal with things like chronic alcoholism and other conditions that impact the pancreas. Next slide, please. So the sore mouth, or odynophagia, can come from a variety of reasons. Medications, and here are some of the culprits here, including nonsteroidal anti-inflammatories and aspirin, which can cause ulcerations. Infections, such as fungus infections from Canada, which you can see on the right-hand side. Probably not such a good picture to have before dinner time here, but this can happen, and we see this clinically. And then viruses cause what's called stomatitis, and those are generally viruses such as herpes, COVID can cause some ulcerations too, so any virus is suspect. Gastroesophageal reflux disease, or GERD, can cause swallowing problems, as well as conditions such as chemotherapy or radiation. Next slide, please. So there's a convergence of problems that occur and cause swallowing problems, what we call dysphagia. These can be muscle weakness. We know that in skeletal muscle, there's 1% loss of lean body mass per year after the age of 60. And so part of the esophagus is associated with skeletal muscle. We know that nerve responses decrease with age, and that there's some structural changes. So it might involve tooth loss, it might involve periodontitis or gum disease, and also dry mouth, which occurs in some studies up to a quarter of the older adult population. And then you add on top of that some disease considerations or chronic conditions such as Parkinsonism, Alzheimer's disease, or cancer. These all can contribute to swallowing problems in the older adult. Next slide, please. And we need to consider that in terms of the esophagus, that there's two levels of innervation. So the top of the esophagus is controlled by the medulla, as seen here in this slide. And small strokes in that area can really cause some swallowing problems. And by contrast, the vagus nerve helps control the esophagus at the lower part of that. And that can be impacted by chronic conditions such as Parkinson's or what we call autonomic neuropathies. The medical terms for that is Scheidegger syndrome, where you have problems with constipation, swallowing problems, and a variety of other things. Blood pressure control is a drop in blood pressure. Orthostasis is also part of that. Next slide, please. So when we talk about esophageal aging, we know that studies show that there is what we call silent aspiration. Don't really know about it and doesn't really always affect you, but it does occur as we get older. And about 2/3 of older adults have some evidence of what we call transfer food changes, or presbyosophagus is another medical term for it. And again, that's just transferring the food bolus from the front of the mouth to the back of the oral cavity, and then down into just above the larynx, right? So that's where you get these coughing fits when people can't, when they have aspiration. And typically if you drink a glass of water and you notice somebody starts coughing about a minute later, that could be indication that they're having aspiration into the lungs. I have a X-ray here that shows the osteoarthritis can cause, in the you can see here that little indentation at the bottom of this X-ray. That's called an osteophyte, and it's pushing in on the esophagus and causing swallowing problems. It's a somewhat of a infrequent condition, but it can occur. And then one of the biggest, whoops, I'm sorry. Yeah, just the last point I wanted to make was that the most common issue is these, with age, you get these simultaneous contractions, and that sometimes, when it's really severe, can lead to what's called jackhammer esophagitis, or some people call it, well, it's jackhammer or corkscrew esophagitis are the two terms that are used. Okay, now we can go to the next slide. So we see here that with age at the bottom of the graph here, that there's an increase or decreased function of the esophagus, and this sort of abnormal contraction, and the aspiration risk starts to occur quite rapidly as we approach 70, and gets worse as we head towards 100 years of age. Next slide, please. So the clinical considerations of swallowing problems or dysphagia is that about 1/3 of the older adults complain of some form of dysphagia or regurgitation or dyspepsia. And that part of the issue is that, you can go for a medical workup on all of this, but only 20 to 30% of these cases are ever identified as having a structural problem, such as that osteophyte that I had pointed out in the X-ray. So typically, this is approached by doing a barium swallow or a video swallow. And the other option is to get what's called manometry. And you can see this with this colorful diagram on the right here. And this is actually a high intensity contraction that's representative of these really spastic, it's like getting a muscle spasm in your food pipe. And again, the new term for this is jackhammer esophagitis. Next slide, please. One of the infrequent but fairly steady observations is this so-called achalasia. You can see with the X-ray on the left there that the esophagus sort of has this dilation, and then it gets narrowed down to what they call a bird beak's appearance. And then there's a diagram next to that that shows the narrowing of that area as it goes through the diaphragm. And there's a variety of ways to approach this. You can have endoscopy and have a dilation. There's also endoscopy-related surgery. There's a magnetic ring that they can place for incompetent sphincters, Botox injection, and other types of surgery. But I listed calcium channel blockers. That's a medication that you could use for this. They generally don't work, but it is one of the options. Next slide, please. Well, the ever famous reflux esophagitis, just about everybody over the age of 60 tends to be on, at one point or another, on a proton pump inhibitor or some other types of medications for like Tums for epigastric burning. And one of the things to consider in this case, and you can see on this graph here that the incidence is somewhat steady throughout the lifespan. So aging per se is not really a huge association with GERD. So it's important to just consider across the lifespan of things that we can do to reduce the reflux, and one of it is weight. And so if you're overweight, that can really promote reflux disease. And in terms of treatment, you want to avoid alcohol, citrus, including tomatoes. So if you like Italian food, tough luck. And then chocolate. In terms of environmental interventions, we always recommend 4 to 6 inches of elevation of the head of the bed. Some people will have an electronic, head of bed elevator. That's another methodology. And then in terms of behavioral interventions, as mentioned, weight loss is important. And then in terms of the medications, using a proton pump inhibitor or an H2 blocker would be good. So something like ranitidine and or omeprazole, lansoprazole. And it's important to point out that when you have dyspepsia and GERD, that sometimes the medication you can change within a class. So sometimes they're not always effective, but if you change to another brand, it'll work better. And nobody knows why that is. But important to point out that use of these PPIs should be short-term. They should be no more than 8 weeks, and then as needed thereafter, unless prescribed differently by a provider. Because the long-term use of proton pump inhibitors is associated with increased risk of community-acquired pneumonia, Alzheimer's disease, and osteoporosis. Next slide, please. So there are certain changes of the stomach as we age. As mentioned earlier, there's a little slower clearance of foods. There's less acid secretion. And most importantly, there's reduced cytoprotection. That mucosal barrier is reduced, and that's why older adults are particularly susceptible to Aleve, Motrin, naproxen and all those non-steroidal anti-inflammatories causing stomach ulcers. And I also want to point out, by the way, that aspirin, no matter whether it's baby aspirin or regular dose aspirin, all have the same rate of gastric ulceration, regardless of the dose. So, and then finally, the whole issue of what we call achlorhydria, which is severe loss of stomach acid, that does occur with increasing age. And in some cases, that might be associated with B12, vitamin B12 deficiency. Next slide, please. So one of the observations with aging is that there is earlier satiation for a given amount of food. And part of the problem is that the stomach is not able to expand quite as readily. There's a little bit more stiffness and fibrosis. And that lack of relaxation that occurs with the aging process is one of the reasons why the stomach kind of shrinks, if you will, and doesn't respond to that relaxation. So that's why people may feel fuller and may eat less as they get older, which we'll talk about nutritionally why that can be an issue too, in terms of not getting enough protein into your system. Next slide. So the concept of dyspepsia is really to distinguish, from esophageal, so reflux disease, gallbladder, or a colon source of discomfort. It's typically an upper abdominal location, and if it's related to the stomach, it's generally a little bit more lingering than a spastic colonic disease. And so, if it's associated with eating or what we call postprandial versus this kind of crampiness that you might get from either constipation or constipation plus diarrhea. Next slide, please. Yeah, so it's just to reemphasize that as we go along, is that cancer is ever prevalent in the aging population. You can see how it peaks here in the 65 to 74-year-old age group. And some of the risk factors seen at the bottom of the slide here include age, as pointed out by this graph. Men are more typically affected than women. However, the BRCA genes may be associated with stomach cancer. And then also being overweight and smoking, as well as harboring a chronic infection with Helicobacter pylori. And then you can see at the very bottom of the slide this wonderful bacon strip. So smoked foods with nitrates have a very, very high risk for cancer, stomach cancer. And so it's this just came out in the last couple of years. And so regular consumption of highly processed foods with nitrates and nitrites remarkably increases your risk for cancer. Next slide, please. Moving on to the small intestines here that are glowing in orange here in the middle on that right part of the slide, is that not much to say really about aging. Things are generally intact with a small bowel, which is, I guess, good news. Compared to the changes in the stomach. But importantly, whey-based protein is better absorbed in some studies compared to legume protein. So people that are plant-based diets, which are better for you, may have some slight reductions in absorption, but really probably not that big of a deal. I want to point out that there's a deficiency of glycine absorption and intake as we age, and that relates to what we call the one carbon chain metabolism, and that's very important for maintaining a good immune system. Generally, the thought is that because of some subtle changes in absorption with age, that there should be an increase in vitamin B12 intake and vitamin D intake, although 800 international units of vitamin D daily is considered pretty good. The question about calcium consumption is controversial because there might be a link in studies on women that too much calcium may cause coronary artery disease and too little may cause osteoporosis. So we don't know quite the right balance yet, but suffice it to say that natural sources of calcium are preferred over to pills. Okay, next slide. There you go. Yeah, so the colon, that really, nothing consistent in terms of age-dependent changes. We know that the so-called myenteric neurons, those are the ones that are related to the nerves that are associated with the gut, tend to decrease, and they are less functional. As a general phenomenon, there's less nitric oxide being produced by the body as we age, just about zeroes out, and that's why people over the age of 65 just about all have high blood pressure, or what we call essential hypertension. It's because the blood vessels can't produce nitric oxide. There might be some outside of the colon, you know, in terms of the, well, on the inside of the colon, really, the lumen, there might be some extra sugars. Some studies going on at University of North Dakota and the Department of Geriatrics are looking at this process and as to whether those changes in sugar metabolism that coats the internal part of the colon leads to changes in the bacteria, going from good bacteria to bad bacteria, and some of the consequences of that. And that's what we call the biome changes. Next slide, please. So there are some very notable colonic disorders. One is constipation as well as obstipation. So obstipation is you don't have a bowel movement after 3 to 4 days. Constipation is just having a hard time getting a bowel movement on a regular basis. I'm not sure that bowel regularity is all that critical of an issue, but some people do consider it an important element in their life. You can see here, this X-ray, there's a lot of speckled spots, and the whole colon is basically filled with stool. And what happens is that sometimes when it gets this bad, you have to manually disimpact it. And you might also get what's called a high impaction, where at the upper part of the colon, you get a blockage. And then what happens is that the liquids in the bowel spill over and they cause diarrhea. And so sometimes a geriatrician may write a prescription for a laxative in face of diarrhea. And it's because we see an X-ray like this. That's the reason. It sounds counterintuitive, but what you're trying to do is relieve the impacted stool. Next slide, please. So diarrhea or loose bowels is not a normal part of aging. There's different versions of diarrhea. So less than 2 weeks would be considered acute diarrhea, and nothing particularly exotic about age-dependent acute diarrhea. It can be either viral, bacterial. COVID can cause diarrhea. And in fact, GI symptoms are one of the more common observations about COVID in the older adult population, as opposed to a cough or loss of smell. I think it's important that when diarrhea occurs is to ask if there's been any change in medications, either an increase or a change in type of medication. Something like metformin is notorious for causing diarrhea. Sometimes the memory medications, the acetylcholinesterase inhibitors, such as Aricept, can cause diarrhea and GI distress. So always think medications when you have a gut problem. The chronic diarrhea, I talked about what's called the high fecal impaction, where you get the spillover of bowel liquids. At least half of long-term care residents have colonization with this nasty bacteria called Clostridium difficile. So C. difficile, colitis, which you can see on the right-hand part of the slide here, these so-called pseudomembranous membranes that are where we see the arrows there, can cause some really refractory diarrhea. There's a common condition called lymphocytic colitis. Don't really know what the long-term implications of that are, but it's basically like an autoimmune disease where instead of the lymphocytes invading joints, they invade the bowel. Loose bowels can also be associated with overactive thyroid, as well as might be a presenting symptom with cancer and or a more benign condition called irritable bowel syndrome. Next slide, please. So we know the cancer of the colon increases with increasing age. It peaks again around the 70 to 75-year-old age group. So that's why we're always trying vigilant for doing cancer screening. Typically after 75, we don't screen for colon cancer so much unless the person's really highly functional and would undergo chemo or surgical therapy if there was cancer found. So to prevent colon cancer, there's certain things we can do in terms of lifestyle. You can stop smoking for one. Some people think that chronic low aspirin, baby aspirin use can help prevent colon cancer. And there's some controversy as to actually whether that is true or not, but there is a association with higher detection of colon cancer earlier when people are taking low dose aspirin. Calcium supplements may or have been associated with a reduction in colon cancer rates. I talked that last point there about avoiding nitrates, so don't eat the bacon unless they are naturally processed. And that's true for cold cuts and lunch meats too that have the nitrates and nitrites. Alcohol has a very strong correlation with all types of solid tumor cancers, including colon cancer. Next slide, please. So when we talk about the liver in late life, there's some distinct changes. Both it shrinks. There's not as good as blood flow as previous years. Interestingly, some studies that try to measure biologic age as opposed to your chronologic age rely upon changes in liver enzyme tests. We also know that both alcohol and caffeine can be reduced in their clearance from the system by the liver. And again, remember the 2-for-1 rule. One drink equals 2 drinks in older adults. So those two martinis in the evening may and should be reduced to maybe 1, if not half a mini martini, if you will. There's some bile flow reduction, which may have some implications for gallbladder disease and for fat absorption. And generally, the liver has a high sensitivity with age to injury. And again, so binge drinking or high consumption of alcohol can really predispose you to liver injury, as well as certain medications. So you have to be mindful of that. Next slide, please. Some of the liver disorders include the chronic viridities, or the Hep B and Hep C. In particular, hepatitis C has been associated with increased risk for liver cancer. There's a age-dependent increase and then leveling off of gallbladder disease, whether it be gallstones, cholelithiasis, or infection, which is much less rare, or is much less common, and that's called cholecystitis. Fatty liver is a big to-do, and a lot of that is associated with chronic alcohol intake at various levels. And I just want to point out this little ultrasound here on the bottom right-hand corner shows a gallbladder with some gallstones in it. And a lot of people have gallstones and they are asymptomatic and you just leave them alone, don't worry about them. But it sometimes can block the bile duct, and then that causes the bile to back up, and it may cause bacteria to back up, and then it causes an infection. So then that needs to be treated. Next slide, please. The pancreas, just is remarkably a stable organ with aging. Its function is pretty much intact. some anatomic changes, and also some fibrosis. The graph on the right here is just shows that with age that the beta cells, both the volume and the size of them decline with increasing age. But again, it usually doesn't turn out to be any functional problems related to that. Next slide, please. So acute pancreatitis can occur, these are all the reasons why you can get pancreatitis. Again, alcohol is the most common cause of pancreatitis, and gallstones is the second most. But there's other reasons. You can have a pancreatic tumor, which is a pretty tough nut to crack. Of all the solid tumors, it's a very difficult tumor to treat. You can get pancreatitis if you have a GI procedure called an ERCP. And then certain medications can cause acute pancreatitis, which this kind of surprised me. I didn't realize that the water pill hydrochlorothiazide could cause that. And that's one of the reasons, well, it's not actually one of the reasons that we give a lower dose of hydrochlorothiazide in the older population is that the kidneys are only sensitive up to a certain level. So we give 12.5 milligrams of hydrochlorothiazide rather than 25 milligrams as an example. Next slide, please. So you can have chronic pancreatitis due to a variety of reasons. Most of it's due to some form of pancreatic duct obstruction, also chronic alcoholism, plus and or minus smoking can be additive towards contributing to chronic pancreatitis. And then medication induced. So the water pills, and again, here was another one that I didn't realize that angiotensinogen converting enzymes medication. So the ACE inhibitors, particularly at higher doses, can be associated with idiopathic chronic pancreatitis. I've not seen it in many cases at all. So even though these are associated with pancreatitis, I would not hesitate to prescribe any of these medications. Next slide, please. So pancreatitis can be broken down into different categories. There's what we call the calcifying pancreatitis. And you can see this on the CT scan here with those little white dots with that little crescent-shaped organ there, which is the pancreas. And again, alcohol and smoking can contribute to that. The obstructive version of pancreatitis can be due to a stricture or to a tumor, which either may be an adenocarcinoma or a benign islet cell tumor or an adenoma. And then diabetes can be associated with pancreatitis or other types of autoimmune disorders. Okay, next slide, please. So you may have seen some commercials on TV talking about ask your doctor if you have exocrine pancreatic insufficiency. And so that's all related to this concept of chronic pancreatitis. Its symptoms are associated with persistent diarrhea. You may have a sense of bloating and have either a lot of burping or passing of gas or flatus. There might be unexplained stomach pain, and at its worst, you'll get what are called floating stools or oily, slicky stools. Next slide, please. And again, a reminder, the pancreatic cancer, as like stomach cancer, increases with increasing age. And so you can just see the epidemiology here. Next slide, please. So an important consideration is that when somebody comes in complaining of gut and bowel problems, sometimes it's not a functional anatomic issue. It's actually what we call somatization, that people had reflected on their bowels and might be having issues with depression or anxiety. And I just have a very vivid memory of a patient who would come to my clinic almost like monthly. You know, and he was complaining of he's always rubbing his stomach. That he had a problem, and then we eventually treated his anxiety. The bowel problems went away mostly. He still complained of some issues because that was his expression of his emotional distress. So anyways, it's just important to understand the linkage between the psychological aspects of bowel function. And so these chronic diffuse pain and syndromes might be often associated with mood disorders. Next slide, please. All right, so I want to spend a little time on nutrition and aging. So as mentioned, there's a 1% loss of lean body mass annually after the age of 60. And that ratio of fat fat just increases with age. And there's an overall 30% obesity. I just looked here in Grand Forks here recently. Our obesity rate is just a touch higher than the national average. We're about 36%. Probably gets worse a little during the winter here too. And the older adults are predisposed to what we call protein calorie undernutrition. And you can see the BMI here on this graph by age group. And the average BMI is just at the verge of normal, with 28 being the cutoff. And you can see that as people get older, that BMI tends to go down. And really, that's probably a self-selection process that people who are that have a high BMI tend to die earlier, and people who have a normal BMI tend to survive. And so obesity is a risk factor for an early death, and these numbers probably reflect that phenomenon. Next slide, please. So just as a reminder, kind of green light, red light here, that the ideal BMI is about 25. And so that's what we try to shoot for. The difference between normal and the yellow, which is overweight, probably is not that great in terms of health outcomes. In fact, there was one study that suggested that if you were in that kind of yellow zone, that it might have protective effects as you got older. But definitely BMIs in the 30 to over 35 range are not good for health. Next slide, please. Yeah, and this just emphasizes that as the BMI increases, going from over 28 to higher, is that there's an exponential increase in mortality. Next slide, please. And this also just emphasizes how the BMI is associated with changes in the population in terms of the mortality rate. So you can see this dark blue line here on the left indicates a BMI of 40 to 50, and that population is well, they just don't make it to 100. So take-home message from this slide is that if you want to make it to 100, your BMI should be around 25. So word to the wise there. Next slide, please. So we know that there's a relationship between physical activity and nutrition, and that's been one of the problems when you want to try and lose weight. You exercise and then you feel hungry and then you eat more, and the body is telling you that you need to eat more. And so that's always that delicate balance. But there's two things to consider here with physical activity. That sedentary lifestyle, I call it bed rest, but if just sitting around, even with adequate nutritional intake, you still get loss of muscle mass. And so oftentimes we see people that when they get hospitalized, they may spend on average 4 to 5 days in the hospital, and then they take another week for recovery, if not more. That 10 days of bed rest, you lose 16% of your strength, and you lose 6% of your muscle mass as a consequence of that. So you know that post-hospitalization, if there's not a game plan for resistance training afterwards, you've really lost a lot. And it predisposes you to falls and frailty as a consequence of that. So I think, if you reflect and ever look at a hospital discharge summary, no doctor's ever prescribed resistance training post-hospitalization, and really we should be. In terms of resistance training, so I'm showing a couple of pictures here of this guy, major weightlifter here. We don't need to be that way. More like the fellow at the bottom there with those green stretchy bands, which is about a medium strength stretchy band of about 6 or 7 pounds worth of weights. And I prefer the stretchy bands just because they're a little bit easier on the muscles and less wear and tear on the joints. But if anybody asks, as we get older, we need more protein than younger years. And so the estimate is 1.5 to 1.6 grams of protein per kilogram daily to sustain lean body mass, particularly when you're doing resistance training. And the resistance training should only be, or only needs to be done minimally twice a week for benefit. You can do more, but it's minimally you need twice a week. And that amounts to about 90 to 110 grams of protein daily. And I'm showing this kind of picture here. I'm not going to say what brand it is because I don't want to promote any brand. So I kind of sketched it out here, but you can see that a lot of these different versions of liquid protein have about 30 grams of protein in them. So you can get a sense of how many bottles you would need. You'd need 3 of those a day if you were not eating anything. Fortunately, our diets do have various sources of protein, and we can talk about that. Next slide, please. So many chronic conditions put a real crimp on protein calorie and cause protein calorie malnutrition. This can be associated with inflammatory changes with aging, a poor appetite, either because of a shrinking stomach or gastritis, due to what we called earlier achlorhydria. It's important to recognize that low serum albumin is a poor prognosticator, and it's actually the cutoff is 3 grams per deciliter is a poor prognostic indice, particularly post-hospitalization. There may be medications that cause appetite suppression as part of your chronic condition. There may be, for instance, with diabetes, there may be some either oral thrush or some fissures and some painful mouth gum disease that might reduce nutritional intake. And then finally, this concept of loss of self-feeding, which is the last of the activities of daily living to go with Alzheimer's disease. But an important point is that if you're dependent upon somebody to for your feeding, that can really be a conduit to malnutrition. Next slide, please. I just wanted to mention the social determinants of health and how they might impact nutrition. That's as you can see in the upper left-hand corner here, that food is one of those elements of social determinants of health. Having access to healthy food alternatives, fresh fruits and vegetables. And, sort of the irony is that even in rural areas where you think there would be an abundance of food, there's not always access to fresh fruits, for example. So these are all important considerations. Next slide, please. So some of the things that might contribute to poor nutrition and aging is loss of smell. That's called anosmia. And interestingly, a recent study out of Britain, where they're doing a huge long COVID study on hundreds of thousands of people from Britain, they found that 63% of long COVIDers have either reduced sense of smell or complete loss of smell that persists. When you lose your smell or have problems with your smell, you get a reduction in taste. And so that concept of ageusia, which is a loss of taste, further impacts your caloric intake. We mentioned earlier about oral changes with painful mouth and gums. Ill-fitting dentures can also contribute to poor eating habits. And then also, if there's a sense of this discombobulated esophagus or oral pharynx, that if there's swallowing issues, people may restrict or limit the amount of food that they take. Next slide, please. So we also want to think about changes in our metabolism. Everybody says as we get older, our metabolism slows down, and that's why we gain weight so much. Probably true. But there's also a decrease in muscle protein synthesis. I already mentioned about the deficiency in glycine, and there's some consideration for supplementing diets and glycine, which can be found in legumes. So lentils, chickpeas, and all those green peas and all that have high levels of glycine in it. We know that there's a decline in the sex hormones and insulin growth factor 1. So that also contributes to a loss of retention, if you will, of muscle strength associated with metabolism. And also, importantly, there's new research that shows that our ATP, our power production, our energy production is reduced with increasing age. There's actually pharmaceutical companies that have been created out of research to promote supplements that ramp up ATP production. It remains to be seen as to whether they really work, but if you're interested in exploring that, there's a company called Genesis that you can look at, and it's producing a vitamin B type compound that enhances ATP production. Okay, next slide, please. So I think importantly, there's a formal or a clinical tool that we can use to evaluate malnutrition. And this is the Nestle, the company Nestle produced this mini nutritional assessment for the older adult population. And this is pretty good, if you use it on a regular basis. If you have somebody that you consider might be frail or might be living alone, socially isolated, any number of reasons that might prompt a nutritional assessment. And this is the form that you would want to use. Next slide, please. So to summarize, we know that age and chronic diseases work together to impact the gut system. And you'll either get hyperfunction, such as you see in with loose bowels, or hypoactive function, such as we see with constipation. We know that age reduces gut resiliency, the ability to bounce back. And so when people have colitis, or if they have C. diff colitis, the recovery period is much slower than a middle-aged population. A word to the wise that if there are either constipation or loose bowel situations or abdominal pain, always look at your medication list firstly. And then most older adults really don't take in enough daily protein. And I think both providers as well as the older adult population does not understand the importance of strength training. Because there's just a steady beat of the drum that just, those muscles go down, down, down. And that's why we've seen 150% increase in fall rates over the past decade, because we're not addressing this issue of consistent resistance training. And then finally, just a side comment is that the gut biome or the bacteria may be changing with age, and it may predispose in some studies towards memory disorders such as Alzheimer's disease. And so they're still studying that relationship between the bad bacteria causing inflammation and then contributing to long-term changes in the brain.